In our last program, if you saw it, you remember one of the psychotherapists said that he couldn't help all his patients because they were too agitated or depressed for cooperation, and they therefore needed some form of physical treatment. If you saw our first program, you may remember that Christopher Mayhew had an interview with a male nurse in a mental hospital about the changes in hospital life that had come about as a result of these sorts of treatment. This is what Christopher Mayhew asked this nurse.
When was the last time that a patient hit out seriously against a member of your staff? Was it this year, for instance?
No, I wouldn't say this year or last year. I still have to go back a long way.
And what do you attribute it to, Mr. Rouse?
Well, I should attribute it to several factors. Of course, drugs and various treatments like ECT, insulin, and of course the open doors have taken away the air of the prison, and they have given a good relationship between the staff and the patient.
Thanks very much.
Well, now that's an important claim, isn't it? And to tell us about these important new developments in physical treatment, we have here in the studio someone who's played as big a part as anyone in developing these methods in this country recently, and he's also written a standard textbook on the subject. So here he is, and the question I want to ask you first is this claim of this male nurse justified, do you think?
Well, the point is, you see, that 20 or 30 years ago, it was no good even starting to open the doors of the mental hospitals because there were so many mentally tortured persons in them.
You mean they were sort of people who wanted to get out and escape and perhaps hard damage themselves?
Yes, I think their suffering was so great that was what they wanted to do so often, or perhaps even to harm other people, you see.
And what do you think is really the most important of these new methods of physical treatment?
I think without doubt it's the treatment of depression by means of electric shock therapy. This treatment can save months of mental agony for patients by shortening attacks of depression from months or years down to a matter of a few weeks. And you see, these treatments do help people who previously were not helped at all by psychotherapeutic methods alone.
And how is it actually done?
Well, we've got somebody here to show you.
Good. Well,
this patient has been good enough to come along tonight to go through the motions of having ECT, electroconvulsive therapy, by a modern method that we use now. And we start off by giving him an anesthetic. We're not actually going to give him treatment because he doesn't need it today. And in any case, we want him to talk to us in a minute about it. This is the anesthetic going in now.
1, 2,
and he counts
3, 4, 5, 6.
So that we can tell exactly when he's gone to sleep. And when this has happened, he has a second injection of a muscle-relaxing drug. This is the most important advance that's been made in this treatment since it was introduced. It almost completely relaxes all the muscles in his body, and it has in fact taken the convulsion out of convulsive treatment. Now he's been given some oxygen. He's quite unconscious, or would be if we had put him to sleep. And now he has this rubber gadget put in his mouth to keep his teeth apart and stop him biting his tongue. And then I put these two pads on his temples like this, and the electricity comes from this box with which we can give a very carefully measured dose. With these two knobs we adjust the dose, and then the current actually passes whilst I press this switch here. Now I'm going to do that again because I want you to watch his toes, because that is usually the only sign that we have that he's had an adequate dose. When I press this, all you see is a little twitch of his toes, like that, and that is as much as you will see of the actual muscular movement of the treatment by this method. That is all the treatment consists of. In a couple of minutes or so, this acute stage is over, and in 5 or 10 minutes, the patient will wake up, and in an hour or two, he'll be ready to go home. Now, I think I should emphasize that this is the method we would prefer to use for all electric shock treatment that's given now. Unfortunately, this is not possible, and a great many people still have this treatment by the old method, which did not involve the use of this muscle-relaxing drug. It is this muscle-relaxing drug which has been the great advance in the treatment, and I only want to reassure you that when it's given by the old method, it is still a very safe treatment. The new advances have made it a much safer and pleasanter one for the patients. Well, now, how many treatments have you had?
6 so far.
And they haven't worried you at all?
No, not at all.
Been all right?
Yes, perfectly all right.
Well, in spite of that statement, we have, you know, had a lot of letters from patients who've complained that they're worried and anxious about ECT. How do you explain that?
Well, you see, it does make some patients much more anxious, it's quite true. But not generally the patients who are most helped by treatment. For instance, this patient who was depressed, depressions are greatly helped. And they will often come up to a general hospital and have this treatment as an outpatient, simply because their illness is far more unpleasant than the treatment.
Yes.
Now, of course, people are worried by the fact that after 1 or 2 or perhaps 4 or 5 treatments, they do get transient upsets in memory, which do clear up after a few weeks.
Yes.
And, of course, there are those people who hate to go unconscious, and others who hate waking up and being a bit bewildered as to where they are for the minute. But
Well, nobody likes an anaesthetic.
No, and you do get anaesthetics, but of course these people are, so to speak, having, 2 anaesthetics a week for 4 or 5 weeks.
Well, rather nice to hear from this patient just exactly...
Well, let's
in
really
more
ask him to
detail.
tell us what he does.
Yes.
Experience.
Well, what I'd really like to ask, first of all, is it at all unpleasant you find this treatment actually unpleasant? Or have you found it unpleasant?
No, not at all. Not at all unpleasant.
Has it been painful at all?
No, no pain at all. A headache, that's about all.
Then has it upset you at all?
No, no, it hasn't upset me at all.
Could you tell us a little bit what you felt like before you started having the treatment?
Well, a general lack of interest in most things and a certain depression.
How long have you been depressed before you came to treatment?
Well, probably for a good 6 months.
About 6 months, were you?
Yes.
Yes. Feeling down and everything?
Yes,
And,
completely down.
are you better now?
I think so, yes.
Now tell me, didn't the first treatment make you at all anxious? I mean, it does some people. I mean, tell us honestly.
I wondered what I was going in for, what it was even.
Yeah,
I didn't know
yeah,
anything about
yeah,
it.
yeah.
I felt so marvelously well after this first treatment that I had
And
no
if
qualms.
you had a recurrence of the illness, would you undergo the treatment again? Would it be worthwhile?
Oh, yes, certainly worthwhile.
Well, that's a very reassuring account, isn't
Yes,
it?
it is.
Now, in the first program in this series, we saw in the outpatient department a treatment by means of insulin, which is called a modified treatment of insulin, I think to increase the patient's appetite, wasn't it? Now, that's one sort. What about the deep insulin treatment I've heard about?
Well, that's a treatment called insulin coma treatment, really. And it was discovered before the war in Vienna, and now practically every mental hospital in this country is using it. It's being used for various mental disorders, among which are schizophrenia. And you know, schizophrenia is one of the most serious of the mental disorders, and it does affect an enormous number of young people, more than any other mental illness. So it is important to find an effective treatment for it, amongst other things.
How is it actually done?
Well, we've got a small film here, done at Netherland Hospital, whose superintendent did so much to help the introduction of this treatment in New England.
Years. An injection of insulin is given early each morning during the course of treatment. The dose is large and will soon make the patients drowsy. A couple of hours or so later, they will go off to sleep. This is light at first. Later, after 3 or 4 hours, the stage of coma is reached, and then the patients can no longer be roused, even by pressing hard above the eye. Coma is ended by bringing the patient round with glucose, which is being prepared here. All the stages of each patient's treatment must occur at exactly the right moment, so all the times are recorded on the blackboard. The glucose can be given through a stomach tube, like this. More often, it is injected into a vein in the patient's arm. The glucose goes straight from the syringe into the patient's blood and is carried rapidly to the brain, where it ends the coma quickly and surely, a reminder of how the brain is affected by chemicals in the blood. The injection goes on until the patient has woken up. The time of awakening, TA, is marked on the board. Patients may be confused and distressed for a while after this, even though safely awake. Then comfort and reassurance from the nurses helps enormously in speeding recovery. Finally, when they are completely round, they get up to a large breakfast. Then they're able to rejoin the daily life of the hospital.
Now, that's a fairly elaborate sort of treatment.
It is, and sometimes you need about 30 treatments, 30 comas, and you may have to combine it with a certain amount of electric shock treatment when there's a strong depressive element. But you see, any treatment that shortens an attack of acute mental illness by as much as a week or 2 or 3 months is well worth it from the patient's point of view.
Now, what about these tranquilizing drugs I've heard about? Aren't they also useful in these cases? May they not perhaps replace insulin treatment one day?
Yes, certainly, I think in some cases they're doing it now. I think it's very promising, and it's one of the great advances, I think, but we're going to need insulin, I think, for quite a long time to come in certain other patients.
Well, now, another method of treatment about which I think there's a lot of concern is this question of operations on the brain, leucotomy. Now, I think we ought to hear something about that.
It's quite true, and for the reason there is so much concern, we've got along, I think, an extremely efficient expert at it. He's written a very well-known book on this treatment. He's followed up 300 patients. He saw them before the operation, and then he's been to their homes, and he's even stayed with them for several days to find out just what the effects are, in view of the wide discussions taking place about it at the present time.
Many of you may remember hearing in previous programs of the complexity of the brain, and may remember it being said that it is composed of millions of cells, and not only cells, but also nerve fibers connecting the cells with each other and with other structures. Now, with his permission, perhaps we might pick the doctor's brains and actually see them at work. This area right at the back is concerned with seeing, and this area below with hearing, while this strip deals with crude sensation, that is, appreciation of touch, pain, heat and cold, and the large unshaded area between those others is concerned with more complicated processes, such as gauging distance and size, and also remembering things in visual and auditory terms, such as what the circus looked like and how the band sounded. Further forward, this strip is concerned with the execution of bodily movements, and further forward again and lower down is an area that deals with speech. But the functions of the most forward parts of the brain, the frontal areas, are less easily defined. We know that they are concerned with the experience of emotion and with habits of thinking, and therefore with those attitudes of mind that determine the personality. Now, the standard operation of leucotomy, which has now been practiced for 20 years, does not involve removing any part of the brain. It is only a question of dividing some nerve fibers in this area. You can see something of this operation by this diagram. First, we come under the scalp to the skull. The approach in this operation is from the side, where you see the arrows. Under the skull, we come to the brain. And then, as I say, nothing is removed, but we are now taking away, just to show you, the area of the brain in which the operation is done. And here is the cut. Now, this operation produces many favorable results, but because the cut is rather extensive, it is liable, in some cases, to produce some undesirable side effects on the personality. Experience has shown that very much about the same benefit can be conferred, and with less, indeed very little, in the way of undesirable side effects, by a smaller operation, which you can see in the other diagram. Again, we come to the skull. The approach in this operation is from above. Under the skull, we come to the brain, and then, again, the brain is not removed, only here to show you the field of operation, and here is the cut. And you can see that it is a very much less extensive one. You may well ask, why is this operation done, and when? It is done mainly to relieve emotional extremes of anxiety, agitation, and depression, when these are not only incapacitating, but are such as to render the patient's lives literally a torment. And the operation is done when all other treatments, if at all appropriate, have first been tried.
But you may also ask, is it not the case that this operation has been much criticized? Yes, it has, and in two main ways. First, on purely theoretical grounds, divorced from actual experience, by people who seem to feel that surgery of this kind is flying in the face of nature, and who are apparently without knowledge of the benefit that it can confer. Second, and much more seriously, by people who have seen bad results. If any of you have seen bad results, I would ask this question. Did you really know what the patient was like before the operation? Now, patients can be made worse, and I have known it, but in my experience, it is rare. And it is really a question of good selection of cases. What far more often happens, indeed so often, is that the operation succeeds in bringing back to freedom a patient who would previously have been irretrievably confined to hospital, with the effect that any personal deficits there may be, previously concealed behind the hospital walls, are now more open to view. Even so, in my opinion, these deficits are far more often due to the illness rather than to the operation itself. There are in this country some thousands of people living at large in the community successfully, and very many of them working. And it is likely that many of you will number among your friends or acquaintances, even perhaps among your employees, people who have been successfully treated by this means, and without your being in the least aware of it.
Now, in spite of all that, there is nonetheless a considerable amount of concern, isn't there, about the possibility of this operation destroying personality?
Yes, I know it only too well, and therefore I think the only thing to do tonight is to ask one of my patients to talk to us.
Yes.
Now, this is a patient of mine who was operated on 7 years ago. He was desperately depressed and agitated, worried about his heart, and what made me really decide to operate after 4 years of illness was this, that his mother had already been ill for 30 years or over, and she actually spent 40 years in her room because of this same condition. And this will show the difference between the old days of treatment of psychiatry and the modern days.
Well, here's the patient. Good evening. Well, here's the patient. Good evening. Now, can you first of all tell me a little bit about what you felt like before this operation was done?
Well, I was very depressed, and I used to think I was going to die. I mean...
Thought you were going to die?
Yes.
Why?
Well, I used to think that I got heart trouble. And
Thought you got heart trouble?
I was very depressed and frightened to move.
Did you go out of the house at all?
I did used to go out, so, but out in the bath chair, and I was frightened to walk.
And there was nothing wrong with his heart?
Nothing wrong with his heart, no, it was just pure panic about his heart.
And what about...
Absolutely, yes.
He was really...
Yes, he was really frightened of himself.
And what about now?
Oh, I'm all right now, sir. I'm A1.
You working?
Yes, sir.
Have you been working since the operation?
Oh, yes,
What
I
do you
do
do?
regular work, bricklaying, sir.
Bricklaying?
Yes, sir.
Really?
Can you do really hard work now? You remember how you used to pant about the place?
Oh, yes, I do hard work now. In fact, I've done a bit of navying, trench digging, and everything in general.
But how's your heart?
Oh, I don't get no trouble with it, sir.
No, but do you think you're going to die now?
No.
But now, the critical thing is, what do you think about your husband? Is he changed at all as a result of the operation?
Not a scrap, sir.
Since before the illness, he's just as good now as he was
He's
then?
just as good, yes, sir.
He's not a different person anyway?
Not a bit.
You sure of that?
Now listen, do you remember that I did warn you about the possibility of these after effects?
Yes,
and
you
do
did.
tell these people, are there any bad effects? Was there
None whatever.
Well, now, would he have come and appeared before this audience tonight?
Well, I don't think he would.
In other words, I think he is a little more free and easy, isn't he?
Yes, sir.
I mean, yes, but
Yes.
he's not rude to you or in any
Not
way.
a scrap, not a scrap.
And he's got the same feelings he had for you.
Absolutely. Absolutely.
Well, now, that is a remarkably good result, isn't it? Wouldn't you say that was
Well,
exceptional?
I don't think it's particularly remarkable. You see, I think one can get these sort of results if one can only choose the right sort of patient for the operation. I mean, sometimes we do have to operate on unsuitable patients. And I think the key to this is this: this patient had a very good previous personality. He'd had a good work record all the time until he got ill. And even when he was ill for 4 years, yet his general personality was very well preserved at the end. I mean, he had these terrible fears, but he was still preserved. And what's more, he did have one of these new modified operations which the previous speaker was talking about.
Now, we have had an awful lot of letters. I've got one here from people who've had leucotomy who are extremely grateful for it. Funnily enough, they're much more grateful than those who had ECT.
I know, it's a very funny thing, this, but I think the reason is this. one probably gets so much gratitude from these people, and I know this is quite true, because they've been ill so long. You see, we don't rush this operation straight away, and if they've been ill, say, for 3 or 4, 5, 6, 7 years, they are more grateful when they're better. The other point is this: the ones that do best with the operation are those who show the greatest amount of anxiety, agitation, and what we call tortured self-concern about their illness.
Yes.
That patient was terribly concerned about himself. And of course, again, when they're better, they're extremely pleased.
I suppose some of the less good results are in fact better than the miserable state that they were in before they ever had the operation.
Well, it's a matter, I mean, sometimes you can't get a very good result, but it's better than nothing, so to speak. And of course, other people stay in mental hospitals, but at least they're relieved of this terrible suffering which they had before.
Well, now, one other form of treatment we did see a little bit of in the first program, and that was somebody having ether dripped over their face with a mask.
Yes, you mean this drug abreaction treatment?
Drug abreaction, yes.
Well, now, we have got somebody again here, a colleague of mine, who's done a lot of work on this during the war, and I think he'll be very interested to talk about it. He's going to show us a film.
Good. Well, over to you.
Most people agree that getting rid of steam or the blowing off of emotion is a beneficial thing. Various drugs have been introduced in recent years in order to help this along. And they include injections of pentothal or sodium amytal or inhalations of ether. Drug abreaction is a method of treatment which has been introduced for patients who have developed neurosis following shattering or terrifying experiences. Yeah. The type of person who may show this form of neurosis is one who tends to black out or lose his memory in the midst of acute stress or strain, or the type of person who totally inhibits his emotions, although his memory for the incident remains intact.
Could you give us an example?
Well, we have an example in a film that we're showing this evening. This is a film of a regular soldier and a sergeant instructor in tanks who went through the Western Desert battles quite successfully until the Battle of Alamein. There, his tank was hit, and from that time, he became ill, he was unable to carry on, was depressed, and went on in this state up to 1950, when he was first admitted into hospital and had his first treatment by abreaction. Well, he had a succession of treatments in this way and improved. He was able to go back to work and carry on a reasonably normal life. Unfortunately, he has just relapsed, and I gave him a treatment last week, which we have now filmed. You will notice at the beginning of the film, I'm attempting to arouse the patient's emotions.
Well, that's it.
He's shouting, I'm blind.
He's shouting he's blind.
Yes.
You can see him now, shouting he's blind.
It's black in the tank.
Everything's black now.
Black. Everything's all dark.
You're in this tank and you're trying to get out now. You're trying to get out of the tank.
We'll get out the top.
Well, get out of the tank now.
I'm on the top. We're going to jump.
What can you see now?
There's a snake moving. There's a snake there. There's a snake.
What are you going to do?
The thing's been blown up.
It's blown up, and you're
Yes.
trying to get out. You're completely trapped now. You can't
sir.
get out.
Yes, sir.
What are you going to do about
I'll
it now?
get out. I'll go to jump, and there's a snake moving.
Well, come on, jump now.
And it stops me from jumping.
Jump. You're going to jump now.
It stops me from jumping.
You're going to shout for some help now.
The driver shouted for help. He said, I'm blind. I'm blind.
You can hear him shouting he's
I'm
blind.
blind.
And you're trying to get out of this tank now.
Yes, and I go to jump, and the snake.
Well, come on, jump now.
I can't jump. There's a snake there.
Well, get some help.
I go to jump, and the snake.
Well, come on, jump now.
I can't jump. There's a snake there.
Well, get some help then.
I crawled down inside the tank.
We then continued for some time in the same vein until the patient began to relive his experiences more vividly. Shortly before the tank incident, which we have just heard about, he got news that a great friend of his, Roger, had been treacherously shot by the enemy. A few months before the tank blew up, you lost your best friend, Roger.
Yes, sir.
And you felt pretty awful about that. You missed him very much. Was that right?
Well, he was in a different battalion from me. He was in 8 Hussars. And they'd already in battle. And we was going up to reinforce this brigade which he was in. And there was a corporal. He said, I've got some bad news for you, Sergeant, he said. He said, your best friend's been murdered.
What do you think about that?
I changed from a pleasant, easygoing lad to a bitter.
You missed Roger very much, didn't you? You even named your child after him. Is that right?
Yes, sir. But I never knew his Christian name till he got killed.
Well, let it go now. Let it all go. Say what you think now. Say what you think loudly if you want to. Let it all go. Blow it out now.
His sister wrote to me, and she said, how's more what you're getting on? He's been dead 3 days then. And I said, I found out his Christian name when I was very ill with this mental. I decided that if I ever got well, I'd have a boy. And that little boy's come and I got his name Roger.
So you've named him Roger, haven't you?
Yes.
You remember, Will, we spent years doing this sort of treatment during the war.
It was very exhausting, wasn't it?
Is it mostly wartime thing? Yeah?
Well, we did a good deal of this work during the war, but it naturally applies to civilian stress and strain too, accidents in civilian life. And a patient
Is
of
it
mine...
effective?
Yes, very effective in the right type of case.
But you must have a severe incident, must you? A traumatic incident, something that really
Yes,
upsets the
it has to be
patient.
something which is really very painful or very terrifying indeed. And I have a patient with me who's kindly consented to come along today. He was involved in a head-on collision in 1952. He didn't work from 1952 to 1954 when I first saw him in hospital. I gave him some abreactive treatment. He had 4 or 5 treatments altogether. And I'm pleased to say he was able to go back to work in a reasonable state.
Did he go over the whole smash, the whole accident?
Yes, he, although he remembered most of the incidents of the actual smash, he didn't remember it entirely.
You mean you got some?
We did get some of his memory back again. And in doing that, there was a very great release of emotion indeed.
Well, I'd like to ask you about it. Good evening. Now that we've heard all about this story, just tell me a little bit what you felt like before the treatment, after this smash.
Well, before the treatment, I felt very depressed,
What were you doing?
nervous. Beg your pardon?
What did you do? Were you
Oh.
working?
I was working at the time, yes.
What were you doing before the treatment?
Well,
Were you still driving?
No. I had to come off the road.
Had to come off the road altogether, did you? And what about the treatment itself? What do you remember of that? Can you tell us what it was like? What
Well,
happened?
I mean, actually, there's nothing in the treatment itself. Of course, it does get to the root of the trouble.
How did you feel? Do you feel well almost at once? Do you feel much better?
Oh, yes. I mean, you don't... there's nothing in the treatment. But, of course, after the first treatment, I felt a little more depressed than I had
Did you?
before. But
Did
after...
Did you have a feeling that you were letting out emotion, would you say, or not?
Yes, definitely. Oh,
You
yes.
did have that feeling?
Yes.
Hmm. And what are you doing now?
Well, I'm market gardening at the present.
Market gardening?
On my own account. Yes.
And feeling fit, are you?
Oh, fine. Lovely.
Good.
And, of course, I did give my driving licence up, but
You gave your driving license
I've
up,
renewed
did you?
it since.
But you renewed it now? Well, good luck to you. Well, there are the various forms of physical treatment we're concerned with this evening. Of course, this sort of treatment is very close to general medicine. A general physician like myself, working in ordinary hospital, not on mental patients, sees a good deal of the value of these drugs. For instance, if we take syphilis of the brain, which used to fill our mental hospitals, now a course of 10 injections of penicillin and it's cured. And then there are people whose thyroid glands here on the neck are not working properly. They may be quite mad or mentally defective. Give them the thyroid extract and they're quite well. And there are vitamins and a number of other things, such as the tranquilizing drugs, which we use in general hospitals. And this is a tremendous development of bringing general medicine and psychiatry close together. Indeed, there are a good many patients, and we never refer to the psychiatrist now, aren't there? Would you agree with that?
It's quite true, yes. Now, I think it's important to emphasize, too, that we're only at the start of this particular treatment approach. I can see great future discoveries occurring here, which will revolutionize psychiatric treatment as we know it today. For instance, we've only got to get better chemical treatments of schizophrenia, and we could get hundreds and even thousands of patients out of the mental hospitals almost overnight.
Isn't that a bit over-optimistic?
No, it isn't, because judging by the events of the last 25 years, I think it's probable. When I entered psychiatry in 1934, there were none of the treatments we've seen today, none of the physical treatments, none of the ones you were referring to. And I was thought to be rather sort of optimistic and one-track mind, and I thought this was a possible line of approach. But I think the next 25 years may be equally exciting to us.
What about psychotherapy?
Well, I think we must mention that. That's most important, because however good physical treatment becomes, and whatever treatment you finally decide to use, you must remember that you're dealing with mentally ill people. And when these people come to you for help, they are often particularly helpless and probably suffering much more than we can ever imagine. Now, therefore, it is important, whatever else we do, that we must give them all the personal help, the sympathy and the support that's in our power until they're on their feet again. And I do hope that providing all these possible approaches are used and combined, that these two treatment programs will have showed how really worthwhile psychiatric treatment is becoming for many patients, how exciting it is for those of us working in it, and what a bright hope I think there is for the future.
Well, that's a most encouraging note to end on, isn't it, in the last of these particular programs we've got here. What I think I've learned is the tremendous range of treatment available now, the way in which the psychotherapeutic approach, talking to and encouraging the patient, analyzing the deep underlying difficulties he has, may be combined with these new and rather exciting dramatic physical methods of treatment. Behind it all, what I've learned is that psychiatrists are doctors. And like the rest of us doctors, what they really want to be is their patient's friend, helper, and advisor. Well, on that note, I think it's good night.